Yeah, we can hear you.
Yes.
Great. So first of all, I wanted to apologize. Today was a crazy day. I was at the critical conference. I gave a lecture. Then after that, a lady with a gas gangrene. I had to go do that. Um, I saw a couple of people down there, at the conference. So anyway, let me just get started. Again, I apologize for coming late here. We don't have a lot of time, but what I'm going to do is, since I didn't have a lot of things put together, what I'm going to do is just go over things that I think is extremely important. So if I'm running a little late, we could just end it. At least I covered the thing that I think is very, very important, or concept that I think I'm going to struggle with, on Monday. So I'm going to start with that first. Because I just got home, so I'm a little all over the place. Sorry. Interesting all the time. Can you guys see this? Oh,
Yes.
all right. Do me a favor. So I think this is one of the areas that I think is going to struggle tomorrow when it comes to acid-base disorders. So I just want to go with that real quick. I was saying in the next 10 minutes, I'm going to time myself so I don't talk too much. So I'm going to be rushing through everything. So what you need to know about acid-base disorder, you have to know how to calculate um, if a patient do have metabolic acidosis, um, alkalosis, compensations, and whatnot. And I think that was discussed. So I want to discuss that real quick, you know. So when it comes to ABG, how do you calculate an imbalance, with the acid base? Um, was discussed, right? In the lecture?
Yes.
All right, good. So do me a favor. I want you to guys to get a pen and a paper, and we're gonna do this together real quick. And on the exam, we're gonna give you normal, so you don't have to memorize this. This normal pH 7.3. I mean, you should know it, but 7.35. PaCO2. You don't have to memorize it. We're gonna give you the numbers, the normals. We'll give it to you. The most important thing is that you must know how to calculate this. You be able to tell us. Are you dealing with acidosis or alkalosis? So when it comes to calculating the ABG, the first thing you have to remember is your pH, right? Normal is 7.35 to 7.5, depends on what lab you're using. Basically, the lower the number, below 7.35, the more acidic. The higher the number, the more alkaline. That's easy. Then the next thing you have to look for is your PaCO2 and also your bicarbonate. Now, your PaCO2 is your respiratory, compensation, whereby your bicarbonate is your metabolic compensation. Um, I'm struggling here with this thing. So they do ask you what two organs are very important when it comes to, acid base, balancing. The organs that we deal with is the respiration and the kidney. All right. So if this is, acting up, the kidney is going to correct what's really going on with the respiration. If there's a problem with respiration, the kidney is going to correct. So basically, they're going back and forth to correct each other. Now, the most important one is your respiration. That's the first initial drive that's going to pretty much do all correction. So respiration is your first, but they both work together. So going back to what I was saying before, so pH, you know that already. PaCO2, again, this talked about respiration, and whereby this talked about your kidney. Okay. And the higher the number of CO2 is, the more acidic. So I think that's where people will have a problem tomorrow. You should know that the higher the CO2, the more acidic. Okay, so normally it's 35 to 45. So if you have a PaCO2 or 49, that means that you have some kind of respiratory, acidosis, right? Same thing when it comes to bicarbonate, 20 to 26, that's normal. Anything that is below is acidic. Anything that's above is, basic or alkaline. So I'm going to stop here. I think people always have an issue with this on the exam. Are we clear with that?
Dr. Sam, I have one question. That's okay. What if they're both abnormal? Then which one do you look at?
I'll get to that. I'm going to explain it.
Okay.
Just the main thing, I'm laying the foundation. When you see PaCO2, now you're talking about your lungs, your respiration, okay? When you're talking about your bicarbonate, your HCO3, that's your kidney, okay? Your metabolic. So metabolic, bicarbonate, respiration is your PaCO2. Now, another thing is that CO2, as it's going up, is acidic. As it's going up, it's acidic, okay? Very important. So now they're diving into it. So the way to really uh, you know, read your ABG, the first thing you have to do is to find out, what is going on my pH. Is my pH acidic or is my pH alkaline? That's the first thing you have to do. That's very easy. The second thing you have to do is what exactly is matching my pH? So, for example, if my pH is acidic, okay, what exactly is matching that pH? Is it the respiration or the metabolic? Is it the CO2 or the bicarbonate? So, whichever one is matching it, that's going to be your diagnosis of what you're dealing with. Okay. So, for example, if I have a pH of 7.1, that's acidic. And if I have my CO2, okay, of 80, that's acidic. So that means I'm dealing with respiratory acidosis. So that's kind of the way you deal with that. And the last thing you have to do is compensation. Is this being compensated? So, for example, if I have a metabolic acidosis, is my lung compensated for the metabolic acidosis? And I'll show you how to do that in a minute. Okay, so let's do this together real quick. So you have a patient. So let's just write down together. You have a patient with a pH of 7.25. Is that acidic or basic?
Acidic.
Acidic. So then the next you have to do is to find out what is matching the acidosis. So let me give an example. So you have CO3 of 24. If you look at the normal, 24 is what? It's normal. Okay, that's not matching the acidosis. Let's look at PaCO2. The PaCO2 is 50. Okay, if you look right here, okay. Somebody saying something? All right. So if you look at the PaCO2, this PaCO2, is this acidic or alkaline? It's 50.
Slightly acidic.
It's acidic. So based on that, because this right here is matching this acidosis, then this patient is dealing with respiratory acidosis. Does that make sense?
Yes. Yep.
Okay. This is where people have a problem with the years. So I want to clarify that. pH, look at the pH first and find which one is matching it. So let's go to the next one. I'll come back to this in a minute. So again, we have a pH which is right here, 7.56. That is basic. Okay. So it's alkaline. So I gotta find which organ, okay, is matching that. Is it the respiratory, which is your PaCO2, or is it the kidney, which is your HCO3? So if you look right here, HCO3 is 22. Again, if you look at it, that's normal, that's perfect. So it cannot be metabolic alkalosis. Now, PaCO2 is 28. Remember 28? The higher the CO2, the more acidic. The lower, the more basic. So this is 28, right? That means it's more alkaline. So this alkalosis is matching this alkalosis, and that makes this patient suffering from respiratory alkalosis. Are we good?
Yeah.
Yes.
Yep.
Okay, so let me give you, just to make sure you guys are following me, let me give you one. Just write this, then I do it together. You have a pH of 7.1, right? And you have the PaCO2, okay, I said 35. Then you have HCO3, okay, of 15. What are you dealing with?
Metabolic
Metabolic
acidosis.
Perfect. Perfect. Thank you. Thank you, God. Perfect. I love it. Let's keep going. All right. So we just did metabolic acidosis right now. That's just done. That's done. That's perfect. Okay. Then this is the last one. Okay. Again, pH 7.5, that's alkalosis. PaCO2 is normal, it's 40, it's normal, it's perfect. So I know I'm dealing with metabolic alkalosis. Okay, so you guys got that. That's beautiful. Let's keep going. The next thing that you have to look for is once you diagnose, what exactly is happening with the patient, alkalosis, acidosis, the next you have to do is obviously to find out which one is the primary cause of the problem, is the lungs or the kidney. So let us say I have a metabolic acidosis. Let's go to this one. I have a metabolic acidosis. Metabolic acidosis. So again, remember the first thing you have to do is find the pH. The second thing you have to do is find which organ. Once you get that organ, the last thing you have to do is, okay, I'm having a problem, okay, with my kidney area, or something is causing me to have metabolic acidosis. Okay, the lungs has to compensate for that. Okay, the next thing you have to look for is the body compensating for the problem? Is the body compensating for the metabolic acidosis? So how do you do that? What you have to look for is, look at this right here. POCO2 is 37. If you look right at 37, is normal. So that's telling me that the body is not compensating for this metabolic acidosis. Does that make sense?
Yep.
Yeah.
Okay. Now watch this. Okay. If this right here is matching this acidosis, perfect. They're matching each other. What if this right here, instead of 37, think about it, now be careful. Instead of being 37, this now become, ready? 20.
Compensated now.
Thank you. Oh, you're the best. Thank you. Does that make sense?
Yes.
Yes. Yes.
If it's normal, there's no compensation. If it's the opposite, for example, this is acidosis, and now you're getting alkalosis, it doesn't make sense. That means there's compensation going on. Now, this is matching this, perfect. So the primary problem is metabolic acidosis. We check that, beautiful. And the next thing we have to do is, do we have compensation? If we have an opposite of my pH, there's compensation, and that's what you have to know. There's more into it. There's something called partial compensation, fully compensation. Don't worry about that. Just know that one. So perfect. So you guys got that. The next thing that you have to know here is if you have metabolic respiratory acidosis, this is where you have to just memorize. I can't help you with this. Just gotta memorize this. Anytime I see or I think of respiratory acidosis, I think the acid is killing the lungs. As it's killing the lungs, you're going to get respiratory depression. So the causes of respiratory acidosis is hyperventilation, CNS depression, like for example, opiate stroke and things like that. You have to memorize this. I don't know how to teach you this. For the exam, you must know how to calculate interpret your ABG. I just did that right now. And then you must find out what are the possible cause of this condition. So for example, this one we said this is respiratory acidosis. What do you think of it happening to that patient? They're going to have a respiratory depression. So what are the things that could lead to respiratory depression? Hyperventilation, CNS depression. That you have to just memorize. I can't teach you that. Does that make sense? Sorry. Okay. The next one is this one. You have respiratory alkalosis. When you see respiratory alkalosis, the opposite of acidosis. So you're going to have hyperventilation. All right. Now, what can lead to hyperventilation? Anxiety, sepsis, pregnancy, drugs, and COVID. One of the things you guys remember here is this city's drug, right? Aspirin, salicylate, okay, could lead to respiratory alkalosis and also to metabolic acidosis, especially the iron gap acidosis. Okay, I'll get to that in a minute. Just wanted to point that out. Okay, are we good there so far?
Yep.
Good. The next one that we have here is metabolic acidosis. For some reason, they love asking questions on this. Love on the exams, board exams, whatever. So what I would say is basically, when it comes to metabolic acidosis, there are two types. They are the anion gap and the non-anion gap. Okay, examples of the non-anion gap is diarrhea and renal tubular acidosis. So for me, what I tend to do, I just memorize these two. And they ask questions on the board. Which of the following is an anion? Which of the following could lead to anion gap acidosis? I just memorized my diarrhea and renal tubular acidosis. If those two are not there, then the answer is whatever. You know what I mean? It's the anion gap acidosis. So what I'm saying is what you have to know here is for metabolic acidosis causes, you're going to see the anion gap acidosis. You're going to see non-anion gap acidosis. Non-anion gap is diarrhea and renal tubular acidosis. And this one is for anion gap. Okay. Now, the last one is metabolic alkalosis. Okay. Anytime I think of metabolic alkalosis, I think of loss of fluid. I think of hypovolemic shock. Okay. So for me, anytime I see metabolic acidosis, I want to give them fluid. That's the best treatment for them. Again, you have to know examples of what could lead to metabolic alkalosis. So usually I don't like to memorize, but this is the area where you have to just memorize these causes. You have to know them. I know there are a bunch of questions on this. Unfortunately, you just got to know it. Okay. Let me see if I covered everything. I covered everything. Yeah, good. So I'm done with that. Okay. How was that? That was too fast. You got it?
Got it.
Dr. Sam, that was good. I just my previous question, where if they're both abnormal, how do you know which one is compensating for the other one, if that makes sense? Like for your
I
example.
thought I answered that. I answered it already.
Okay, so sorry, I must
let
have
me
missed
just
that.
repeat that. Let me repeat that. So let me repeat and go back and repeat. So if they're both not abnormal, watch this. This is alkalosis. So let us say this is also acidosis, and this
Okay.
is alkalosis, right? So this is
Yeah.
abnormal. That's abnormal.
Okay.
Which one do you think is a primary cause of the condition?
I don't know how you would be able to tell.
Okay.
Is it because of the pH? You're saying the pH?
Let me just make sure. I want to make sure you maybe think. By the way, thank you for answering that question. Does anybody have any question about this? Okay, so let me just go through this. I think it's only one person. That's fine. I want to make sure you guys get this. So if you look at this, if you think about it, this one right here is acidosis. The first thing you have to, if you remember what I said, that the first thing you have to do is look at the pH. What exactly is going to pH has to match one of this. Okay, has to match your respiratory or your metabolic, right? Whichever one that matches this pH, that's the primary issue.
Got it. Thank you. That's perfect. Thank you so much.
So
Yeah,
if you
I
look
got
right
it.
here, alkalosis. So we're dealing with metabolic alkalosis, right?
Got you.
Then this right here would
Is
now
the
be the
compensation.
compensate. There you go. You got it.
Got
That's
it.
it.
Thank you. Thank you.
All right. Was that explained like that in your lecture? No? Yes?
You did it better.
No, well, don't say that. Okay, let's go to another one. So another one that is a problem that I think is good. You guys are gonna have an issue with. Let me find it. Give me 1 minute. And it's on GI. This is another problem here. It's gonna be a big problem. Make sure we got this out of the way. Okay, let me go here. This is the one. Yes. All right, can you guys see this?
Yes.
Okay.
Yeah.
So the first one I just discussed was your interpretation of ABG. I think there's like a bunch of questions on that on the exam, maybe 3 or 5. I can't remember. I think 5 questions, 6 questions. Anyway, and this one also, a bunch of questions on this too. I think people might be confused with this, but you must know how to interpret this also. So when it comes to hepatitis B, there's something called hepatitis B core. The core is the core or the gene of the virus. Okay, so it's hepatitis B core antigen. That's the core of the virus. For some reason, they can't test for it. I don't know. It's kind of weird. Anyway, the next one is hepatitis B surface antigen. The surface antigen is pretty much is expressed, when someone's got an infection. The core is not seen, but the surface is seen. Is pretty much when the patient has an infection. So anytime you have hepatitis B surface antigen, that means you have an infection. You have hepatitis B infection. Is it acute? Is it chronic? We don't know, but we know that you have that person's got an infection. So that's what that means. Hepatitis B antigen. When you see antigen, that means the virus is expressed. So, and where is it expressed? On the surface, that means it's an infection. On the core, that's within the core of the virus. There's something called the antibody, hepatitis B E, which is called envelope. Okay, that just means that, can a person transmit it? So this is positive. That means a person could transmit the hepatitis B. Then the next you have to look for is the antibody, okay, to the antigen. The first thing you have to look for is there any antibody to the core. Okay, you have to remember we can't measure the core, for somebody's going to deep down, but we can measure the antibody against the core. So when you have antibody against the core, that means that you have some kind of infection before or ongoing infection. Okay, so this is where it gets a little confusing because the hepatitis B surface antigen tells you have an infection, acute or chronic. And the antibody tells you, wait a minute, I've been infected before and I'm producing antibody. You can't produce antibody without an infection. It's impossible. There's got to be an infection or vaccination. Okay. So that's how you interpret this. So if I have antibody to the core, that means there's an infection going on before or it's an ongoing infection. The next thing you have to now look for is, okay, now I have this antibody against the core. That means I have an infection somewhere, but is the infection going on right now, which is IgM? If you have IgM, it's an acute infection. If you have IgG, that's a chronic infection. Okay. Again, antibody I don't think I have to note this, but whatever. Don't worry about this. But the main thing is this one: antibody against the surface. Okay, that means that you have some kind of immunity. Okay, against the virus. So antibody against the hepatitis B surface, that means you have immunity or you have some kind of vaccination. Okay. Any questions? There's going to be some practice question in a minute. But the main thing you have to just remember is these two right. These two are very confusing. This right here and this right here. Okay. So with this, think about it. You have hepatitis B surface antigen. What's on the surface? That means I have an infection. The question is the infection acute or chronic? You have no clue. Okay. The only way to tell is to look at the antibody to the core. Okay. If the antibody to the core is IgM, that means you have an acute. If it's IgG, you have a chronic. If you have antibodies to the surface, that means you have immunity and you have some kind of vaccination. So let's do some tests, which is what you're going to see in your exam. Okay. If I have, and you could answer the question, if I have hepatitis B surface antigen and it's negative, okay, that means I have no infection. True or false?
True.
True.
Got it. Now you have antibody against the core. Antibody against the core means that you have some kind of infection before and your body is trying to fight it, right? Trying to fight it. And they say this one is negative too. Okay, perfect. So I have no infection. But look at this one. You have antibody, okay, to the surface. That is also negative. That means I have no immunity. If I ever get stuck by a needle, I have no immunity. That's what this means. So based on what I just told you, what do you think is your interpretation with this patient? Your interpretation is going to say, this patient never had an infection to hepatitis B, but they are susceptible because they do not have this right here, the immunity, which is the antibody against hepatitis B surface. I think I lost you guys.
No, you're good.
No, that was
Oh, so we're good?
Go
Okay,
ahead.
good. All right, so let's go to the next one. Hepatitis B surface antigen. is negative. That means what? I don't have an infection. So let's go to this one. Antibody against the core is wait a minute, it's positive. That means what? I'm reacting, my body's producing antibody against an infection. Okay? Against an infection, right? Am I right? So is this infection acute or chronic? Can anybody tell me?
Depends on the IG. If it's
So I don't
then it's
know.
acute. Yeah, you don't know.
I don't know. I don't know. I have no idea. Does the patient have immunity?
Yes.
Yeah.
Yes. So this
Wouldn't you
patient,
just assume that it's chronic based on the other two? If you don't have a current infection and you're immune to it, wouldn't you just assume that it's the IgG?
Debbie, you're too fast for me. I was going to explain that later, but you jumped the gun. Thank you, Debbie. You're 100% correct. I was afraid of how I'm going to explain this, but you're 100% correct. If you have a patient, right, that's got antibody core, all right, and they don't give you nothing at all, you should, and they have some kind of immunity, you should assume that you're dealing with chronic infection. Okay? You have a chronic infection. Okay? Or if they say the IgM is negative, they pretty much tell you have a chronic infection. And Debbie just said it perfectly. Do you guys get that?
Yeah.
Okay. So what do you think is the answer here?
They were infected and cleared it naturally.
Right. So basically, the patient has immunity. Again, think of this antibody surface, okay, to be immunity. So they have immunity, okay, to an infection from the core. Remember, from infection, that's a natural infection. So let's go to the next one. So you have antibody, okay. So it's hepatitis B surface antigen is negative. You have the antibody to the core, which is also negative. That means I don't have an infection. But guess what? I have immunity. The hell is going on?
I was
Vaccinated.
That's right. That's right. That's right. That's right. You got it. Vaccination. Let's keep going. You have surface antigen that's positive, right? That means I have an infection, acute or chronic. I don't know. Let's keep going. You have antibody against the core. Okay. So that means, again, I have antibody fighting an infection. I got to find out which is it acute or chronic? I don't know yet. IgM antibody, guess what? It's positive. What is that?
Acute.
Acute infection.
That's right. You have an acute infection, but guess what? Our antibody to the surface is negative. So that means I have an acute infection, but I do not have immunity. Make sense?
Yes.
Okay, let's keep going. This is positive. Antigen is positive. The core is positive. IgM is negative. Based on this, am I dealing with a chronic infection or acute infection?
Chronic.
Chronic.
Debbie jumped the gun. Thank you, Debbie, for doing my job. Good job, though. Good job. So then you have antibody to the surface is negative. What does that mean?
Not immune.
But you got to start first with there's a chronic infection with no immunity, right? Got it? So what about this last one? This is negative. This is positive. What does that mean?
That you previously were exposed to the infection.
That's right. That's right. And you have what? No immunity. Okay. All right. Again, negative, negative, negative. That means you are susceptible. Why susceptible? Because of this baby right here. Antibody to the surface is negative. You have no immunity, so you're susceptible, right? Are we good with this? Yes?
Yes.
Yes.
Okay, so I think that's another one that's going to get you a little bit. I think those two, I just want to make sure I go over them. What else is very important that I think is very confusing? I think that pleural effusion. Pleural effusion. What is that? No, that's not it. No. GI. This is. Let me just go. Let me just start from the GI and just keep going. And I think those two, I think, were the most important ones to cover. That I think if I don't get time to finish my review, then at least I covered the most important. The rest of them, if you study, you should be fine. Okay. So when it comes to, oh, by the way, sorry, the exam is 60 question. Okay. You have 1 hour 40 minutes for the exam. We're gonna start the exam at 7:15. I think you guys have like 30 minutes, what do you call it? 30 minutes grace period, something like that. Halfway mark, whatever you call that thing. Some people don't like to come a little early. They like to come at 7:30. I think it's on purpose. It's on purpose. So if you don't want to come at 7:15, you don't have to come at 7:15. Just come at 7:30. I strongly believe that the question I'll say there's about 20 questions that I call I gotcha kind of question. I hate I gotcha kind of question. There are 20 questions like that that you have to like, and the answers are in the book. They are in the book. If you read the book, it should be fine. Should be a problem at all. There's no reason why everybody should not get 100 tomorrow. There's no reason why. If you read the book and follow my instruction. So there's 20 questions that I think is a little got me kind of question. And I think you're going to spend a little more time with those 20 questions. The rest of the question, about 40 questions, literally, you could spend 2 seconds and answer this question like that. Boom, boom. So I personally believe that you could finish the exam in 1 hour, 20 minutes. I strongly believe that. For me, personally. But again, I do you guys a favor. I'm giving you 1 hour, 40 minutes. You don't have to come 7:15. You come at 7:30. Okay? Okay. That said, let me start with the GERD. So I need a volunteer. Just talk to me. What is a GERD? What is that? A volunteer.
Gastroesophageal reflux disease.
Okay. What is the number one condition that people could miss with GERD?
Is it Barrett's?
Mm-mm.
Cardiac.
Cardiac. MI. Okay. GERD actually is the most common cause of non-cardiac, chest pain. So a person that's having chest pain, okay, do you have any acid reflux? Yeah, I do get acid reflux. It's acid reflux. Go home, not knowing that the patient has some kind of, MI. So my recommendation is anytime you have a patient who's got a chest pain, okay, don't forget what we talked about. The first thing you have to do, even if they have a history of GERD, the first thing you have to do is what?
EKG.
That's right. Gotta get an EKG. Follow the process. Follow the process. If you could just normal chest is negative, everything is negative, then you can now say, you know what, I've ruled out everything, and now this patient's got a GERD, and I'm gonna treat them with that. So that's the first thing I want you guys to remember. So another thing I want you guys to remember here is when you have a GERD, basically you have some kind of content of the stomach going to the esophagus, right? What about when you have a content within the stomach that is causing inflammation of the stomach? What do you call that? What's the diagnosis?
Gastritis.
Gastritis. That's right. Gastritis. I just make sure you guys remember that. So when you have GERD, the best way to treat these people is to give them H2 blocker. True or false?
False.
Thank you. What is the best treatment for GERD?
PPI.
Proton pump inhibitor.
Exactly, PPI. So if I have a patient with GERD, right, I give them PPI, and they're not getting better, what is the next thing I have to do for them?
Optimize
Give
PPI.
more PPI.
And
Optimize PPI. So listen to me. Don't mess this up. Mess it up. The first thing you have to do for these people with GERD, with the PUD and all these people, you have to start with PPI. If the PPI is not working, you have to optimize PPI. You have to increase the dose. Okay. If that's still not working, what's the next you have to do?
Upper endoscopy.
You got it. Endoscopy. When you get in there to, well, not you, we don't do that. When they get in there to do the endoscopy, what is the number one thing you have to do or you must do when you get in there?
Take a biopsy for H. pylori.
That's right. That's number one. Thank you. Number one. You want to do a biopsy for H. pylori. You want to check for any peptic ulceration. But the most important thing you want to do is to do a biopsy for H. pylori. If you do a biopsy for H. pylori, it comes back positive. How do you treat that?
Triple therapy.
That's right. You got it. Okay.
Dietary
This-
restrictions before you go on PPI therapy.
That's the absolute. Absolutely. Yeah. Absolutely. Now, the next thing is, I'm writing this down to make sure I remember this sequence. If I have a patient with PUD, what is the group of, let's say this, what is the group of pharmacologics that you have to tell them to stop using?
NSAIDs.
NSAIDs, thank you. NSAIDs, that's right, NSAIDs. And obviously you want to put this patient on PPI. True or false, PPI could help improve the healing of a peptic ulcer.
True.
Man, you guys on fire. I love it. Okay, now watch this. I do PPI. Okay, it's not helping. I optimize PPI. It's still not helping. I do upper endoscopy. I do my biopsy for my H. pylori, right? Boom, negative. But I still notice that I have a peptic ulceration. What is the next thing that I have to do?
A gastrin test?
Yes. Thank you. Gastrin test to rule out carcinoma. Absolutely. That's it. And that's what you have to know about this. Okay. So that sequence, you should always remember that. You start with PPI, it's not working. You optimize PPI, it's not working. Upper endoscopy, right? When you get in there, do H. pylori test. If it's positive, triple therapy. Okay. And basically, if the H. pylori is negative, you wanted to make sure you test for gastrin. Okay. All right. Good job. The next I wanted to talk about, this is one of the I gotcha kind of questions. Anyway, the next I wanted to talk about, if you pay attention to me, you'll be fine, is basically when it comes to the esophagus, what do you see in the esophagus? What kind of cell do you see in the esophagus?
Squamous
Columnar.
epithelium.
Squamous cell? Okay.
In a healthy esophagus.
So the esophagus is squamous cell, right?
Yes.
Yeah. So, do you know how many attendings love the ECs? Can anybody guess?
0.
We like the students, but we don't like the idea of EC. We don't like the idea, So why am I saying that? So think about no doctors like the ECs, not the student, just the idea of EC. The E is the esophagus. Agree? All right. And the C is the columna. The question is, do you want to see a columnar epithelium in the esophagus?
No.
No.
Do you think the doctors want to see ECs?
Yeah.
I don't know. That's my way of remembering it. I thought that's funny. I thought that was funny. I just want to use that. Anyway, what I'm saying is, for me, the way I remember this, is EC. EC. Then there's something called the SS. Sickle cell. Nobody want to have sickle cell, so the stomach doesn't like squamous cell. SS. I don't know. That's stupid. But that's my mnemonic. I'm not sure it's going to work for you. Just memorize it. Are we good? Yes?
Yep.
Yes.
All right, good. So just know that. So the next thing, actually, you know what? I like that. Give me 1 minute. I like that a lot. I just thought about it. I'm sorry, pretty soon. I like that. I like that. You see, it says, sorry. I like that. Okay, why am I struggling? Sorry, guys. Almost done. Almost done. I'm trying to do something. I don't want to forget it. I like it. Okay. All right. So anyway, so when it comes to Barrett's esophagus, it's a pre-malignant condition. And one of the biggest things is that this condition will lead to what kind of cancer?
Adenocarcinoma.
Adenocarcinoma.
Adenocarcinoma will only lead to adenocarcinoma, nothing else. Okay, and that's the only thing you have to know about that. Let me keep going. And we discussed this already. That's done. Okay, good. PUD. So when it comes to PUD, peptic ulcer disease, it's divided into two. You have the gastric ulcer and the duodenal ulcer. Again, I got this from the book, literally from the book. Okay. So with the gastric ulcer, these people, when the food passes through the stomach, they have severe pain. Okay. So these people actually, they lose their appetite. Okay. And people with gastric ulcers, they tend to lose a lot of weight because they are afraid to eat. Okay. On the other end, with duodenal ulcerations, as a matter of fact, their pain is improved with food. So these people gain weight. Okay. So that's the only difference between, PUD, the gastric or the duodenal. Duodenal, they gain weight. The gastric, they lose weight. Okay, we discussed this already. Okay. The most important when it comes to PUD, or when it comes to GERD, you want to stay, especially PUD, you want to stay away from NSAIDs, stay away from salicylic. You want to give them PPI. You want to rule out H. pylori and treat it with triple therapy. And you want to rule out gastrinoma by ordering gastrin. Okay. All right. Any questions about that? I'm kind of rushing a little bit. Are we good?
Yeah.
If you don't talk to me,
Yeah.
I'm gonna be okay. Good. The next thing I wanted to talk about is when you have gallbladder issues. So as you guys all know that bile is produced in the liver. Okay. And basically, as the liver is producing the bile, is being stored in the gallbladder. Okay. Basically, as the fluid is coming, is going to the cystic duct. This becomes very important. Cystic duct. The fluid goes in there, the bile will go in there, and boom, will be stored in the gallbladder. Also, the fluid in the gallbladder could be released, okay, through the common bile ducts and straight down to be released, to the feces. So it's very important that you remember what a cystic duct does and what a common bile duct does. The reason why that's very important because when you block the common bile duct, okay, you're going to get cholelithiasis. When you block the cystic duct, you're gonna have cholelithiasis, and if you block the common bile duct, you're gonna get cholelithiasis, which is your cholangitis. Okay, so a couple of questions here. Why is it that when people eat fatty food, they get severe pain in their right upper quadrant?
Because you release more bile when you eat fatty foods.
That's right. So people with cholelithiasis, people with gallstone, your cholelithiasis. Basically, the more fatty food you eat, the you're gonna get a release of bowel. So basically, this patient has severe pain. So on your question stem, look for a patient was eating a lot of fatty food and they're having a lot of abdominal pain, especially on the right upper quadrant. When you hear that, they're kind of leading you towards your cholelithiasis, cholecystitis, cholelithiasis, and cholangitis. Okay, good. Which one is worse, cholangitis or cholelithiasis?
Cholangitis.
Cholangitis.
Good, excellent. So right there, okay, the lowest is your cholelithiasis. As you go down, you're gonna get, your cholangitis. If I have inflammation of the gallbladder, sorry, not inflammation. Sorry. If I have stones, sorry, if I have stones within the gallbladder, what do you call that? Which one is that?
Cholelithiasis.
Cholelithiasis. If I have cholelithiasis with an infection or inflammation, which also includes the cystic duct. So you have inflammation, cystic duct, inflammation of the gallbladder. What do you call that?
Cholecystitis.
That's right. If I have a blockage, a stone that is blocking the common bowel duct with no infection, just blocking it, I've done this, no infection. What do you call that?
Choledocholelithiasis.
Cholelithiasis. If I have an infection, that's cholangitis. True or false? It's very important that you do emergent procedure with cholangitis.
True.
True.
That's right. Good. So right here, you have stones in the gallbladder. Okay, that is called cholelithiasis, and basically, these people will say they have a colicky pain in the right upper quadrant. So when it comes to, let me go back here. When it comes to cholelithiasis and cholecystitis, the best way to diagnose them is with ultrasound. Those two, always ultrasound, always ultrasound. Now, when it comes to cholecystitis, you could use HIDA scan, but for those two, the best way to diagnose them is to use ultrasound. Okay. So anyway, they have colicky pain, but they have no inflammation and they have no fever. With this cholelithiasis, basically these people that have obstruction, okay, and inflammation of the cystic duct and also the gallbladder, okay, they're gonna have a constant pain. They're gonna have fever. That's the most important thing: fever, or leukocytosis. But the most important way to diagnose this condition, very easy, is to check for Murphy sign. A Murphy sign is when you press on the right upper quadrant. When you press on it, you tell the patient to inspire, to breathe in. Okay, and as they're breathing in, what's going to happen? Your pressure that you have is going to put pressure on the gallbladder, and that's going to cause severe pain. So people with cholecystitis, they have positive Murphy sign. A positive Murphy sign is when you breathe in, okay, and you have severe pain when someone is pushing on the right upper quadrant. That's what's called a positive Murphy sign. That's pathognomonic for cholecystitis. Once you see a positive Murphy sign, you're done. That's your diagnosis. Then the next thing to look for is, do I have fever? Okay, do I have leukocytosis? And they're going to ask you, what's the best, imaging study you're going to order for this? You're going to say ultrasound, or IRIS scan. And the treatment for this is cholecystectomy. Again, treatment for this is elective cholecystectomy. Treatment for this is also elective cholecystectomy, and give antibiotics.
Is it an abdominal ultrasound or EUS?
Ultrasound.
Is ultrasound?
Abdominal ultrasound.
Okay.
Yeah. Okay. We discussed this already. Basically, you have something that is blocking. I think someone asked biliary colic. Yes, that is same thing as cholelithiasis. Yeah, that's true. Yes, you're correct. That is true. So cholelithiasis, pretty much we have some kind of blockage within the common bile duct. Okay, now you're going to get some kind of obstruction, you get some kind of inflammation, but you do not have infection. The best way to diagnose these people is to do ERCP. ERCP could be used to diagnose them, and ERCP could be used to treat them. Okay. The next one, there's a video. I don't want to show you that video. Let's keep going. There's no time for that. The next one is cholangitis. This one is the problem here. Cholangitis is basically you have a cholangitis with the infection. You have the Charcot triad, and you have something called the Reynolds pentad, and I'll talk about that in a minute. You could do, right upper quadrant ultrasound, and then one of the emergent, ERCP. So there's a summary slide here. Biliary colic, cholangitis, right? Cholangitis. You have pain in the right upper quadrant, and that's it. Colicky pain. Cholecystitis, you have pain in the upper quadrant and a fever, and that's it. Cholangitis will give you your triad. They call it Charcot's triad. Okay, where you're gonna have upper quadrant pain, gonna have fever, and you're gonna have obstructive jaundice. Okay. Also, as the disease progresses, if you don't take care of it as soon as possible, these people will develop sepsis, and they'll have altered mental status, which is called the Reynolds pentad. Any questions? Did I lose you?
No, we're good.
Okay. So let's just ask you a question. What word, if I say one word that would give it away that I'm dealing with biliary colic, what will you say?
Murphy's sign?
No. Biliary
Well,
colic.
pain.
Colicky pain. That's the word. Colicky pain. Okay. One word that will give it away that I'm talking about cholecystitis. Cholecystitis.
Murphy's.
Morphes. One word that will give it away that I'm doing cholangitis.
Jaundice.
Fever with jaundice. Well, two words. Fever with jaundice. Okay. Good job. Excellent. Okay, that's the summary. And that's it for that. Any questions?
No.
I think the most important thing you have to know here, which one is worse, you got that. How do you treat it? You got that. The most important thing, pick one word or two words that will really kind of help you out diagnose this condition. Colic pain, right upper quadrant, boom, you're done. Cholecystitis, basically positive morphes, and they have fever. And cholangitis, they have the Charcot's triad, okay, or the Reynolds pentad. The next one is cirrhosis. This is huge. This is very important. What is cirrhosis? Just fibrosis of the liver. When you have fibrosis of the liver, true or false, you're going to have increased production of vitamin A. Anyone?
Repeat the question.
False.
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 Yeah,
Because
decreased.
a decrease. So if you have liver cirrhosis, that means your liver is not producing vitamin A. So you have decrease. True or false? You're going to have decreased clotting factors.
True.
True.
Good. You're going to have increased albumin.
False.
Good. You're going to have increase of portal hypertension.
True.
True.
You're going to have backup of blood into the system, and that could lead to viruses.
True.
True.
That's it. You got it. So basically, this diagram is very important that you should know this diagram. So as you know, every organ uses oxygen, right? Once they're done with the oxygen, basically the blood turns to deoxygenation. And that designated blood has got to go back into the liver and back into the hepatic vein and into the inferior vena cava. This right here, your portal vein, is so important because you cannot send anything from the stomach, from the spleen, straight into the inferior vena cava, because what happens is that you're gonna induce toxins into the brain, or into the heart, or into the lungs. So the liver has to filter that. Okay, it has to filter these negative metabolites. Okay, so now you have all this organ that is draining everything into portal vein. So portal vein is so important to take this deoxygenated blood into the liver to be filtered, and once they are filtered, they go into the hepatic vein, and from there they go into the inferior vena cava. The problem is if you have an obstruction, okay, that is causing blood to back up into this organ, that's when you're going to have increased portal hypertension. Let me give you an example. There is something called prehepatic, intrahepatic, and posthepatic. So prehepatic is if I have a clot right here, right? I have a clot right here on the portal, that's prehepatic. So that means every single blood that's coming from here will go back, retrograde, will go back. And as they're going back, that will lead to viruses. Okay. If you go into the stomach, you're going to get, what do you call that? If you go into the stomach and small intestine.
Aptus medusa.
That's right. If you go to the esophagus, what do you call it?
Esophageal
varices.
If it happens in the anal, what do you call it?
Rectal.
That's right. You got it. Absolutely, you got it. So if you have a problem with your liver itself, guess what? Everything will also back out, back out into the portal vein. There is something called Buchiari syndrome. This is when you have a blood clot within the hepatic vein. Again, instead of the blood going into the inferior vena cava, everything is going back. So you have to remember that. So anyway, what I'm trying to say is if everything is going back, that's going to cause this vein to engulf and to get bigger, and that will lead to increased portal hypertension. When you have increased portal hypertension, then everything else will happen that we just mentioned. And we just mentioned that viruses, bleeding, so you guys got this already. So basically, when you have increased portal hypertension, you're going to get ascites, you're going to get peripheral edema, right? You're going to get viruses, and you're going to get splenomegaly. These are the 4 manifestations of portal hypertension or liver cirrhosis. Anytime you hear liver cirrhosis, think of these 4 things: ascites, peripheral edema, viruses, and splenomegaly. Okay? This you have to memorize. I think I got it from the book, from the PowerPoint. This you have to memorize. Let me tell you why you have to memorize this. If I ask you in America, what is the number 1 cause of liver cirrhosis? What would you say?
Alcohol.
Alcohol. How can you tell? What test can you order to see if the patient has liver cirrhosis from alcohol?
AST.
AST what?
ALT.
I know, but there you go. That's what I want to hear. Thank you. So basically, your AST is going to be extremely elevated as compared to your ALT, usually 2 to 1, usually 3 to 1. When you have an advanced stage, it could be 4 to 1, but usually your AST is severely higher or 2 to 1 higher than your ALT. That's how you diagnose it. The next one is your hepatitis B and C. What is the biggest sequelae of hepatitis B and C?
Hepatocellular carcinoma.
Cirrhosis.
Hepatocarcinoma, right? Hepatocellular carcinoma. Don't forget that. There is something called autoimmune hepatitis that could lead to cirrhosis. There's something called non-alcoholic steatohepatitis. The next one I wanted to talk about is so important. You have to remember this. Something called the biliary cirrhosis, okay, or they call it biliary cholangitis. And I'll talk about that in a minute. So the way they're going to test you on the exam, is they will give you a scenario and they want you to tell them, what exactly in this list that is causing the cirrhosis. So let me give an example. A patient presents with positive AMA, and they are having severe scarring of their liver. Which one of these is causing the cirrhosis?
Primary biliary cirrhosis.
Who said that?
Me.
Oh, you're the smartest. Perfect. Beautiful. Let me give you another one. You have a patient that has got esophageal viruses. Patient has difficulty breathing. You check the liver. The liver pretty much showed fibrosis. This patient says that they've been having productive cough for 3 months, for 2 consecutive years. That's not getting better. Which one of this is causing the cirrhosis?
Is it alpha-1 antitrypsin?
Yes, yes. Beautiful. Man, you're on fire. Do these guys get that what I'm doing? You guys see what I'm doing? No? Everybody confused?
That
Yeah,
makes
you're
sense.
good.
Okay. So this is the way we're going to ask you these questions. Get ready. Know it. Know everything about everything here on the slide. They'll give you a scenario and just, find out which one is causing what. Okay? All right. By the way, what I just described earlier, what's your diagnosis? Productive cough?
Chronic bronchitis.
That's right. That's right. You got it. You got it. Okay. Okay, we discussed this already. So discussed this already. Discussed that already. Oh, low albumin, right? It's low albumin. Discussed that already. I want to show a mnemonic. Where's my? There you go. There you go. So when you see liver cirrhosis, you're going to get ascites. You're going to see bleeding, corpus medusa, diminished liver function, and enlarged spleen. I don't know. Just another mnemonic if you want to use it. I want to keep that. Okay. Question. A patient with chronic fibrosis of the liver, they have jaundice, they have esophageal viruses, right? They have a positive anti-mitochondrial antibody. What is the cause of this liver disease? Somebody said it before. Primary biliary cirrhosis, also called primary biliary cholangitis. This right here, is usually caused by an autoimmune disease. And what is going on is that this antibody does affect and destroy the bile ducts. It's an autoimmune disease against the bile ducts. It will destroy the bile ducts and render the liver useless. And pretty much they call it the primary biliary cholangitis. So when you have autoimmune disease, okay, creating the production of AMA, anti-mitochondrial antibody, and that ANA destroys the bile duct, you're going to get that primary biliary cholangitis. The next one, okay, is primary sclerosing cholangitis. What is causing this? This is caused by AMA. What is causing this? It's from the book, by the way. It's from the book.
Crohn's disease, ulcerative colitis.
That's right. IBD. Just always say IBD. IBD. Okay. So this is pretty much just an inflammatory process going on that is caused by either your Crohn's disease or your ulcerative colitis, and that causes severe inflammation to destroy the bile duct, okay, leading to sclerosis. So this is caused by ulcerative colitis or Crohn's disease, whereby this one is caused by the antibody. And the way I remember this, for me, again, mnemonic, stupid, but A, B, A, B. So primary biliary cholangitis, biliary, A, B, they go together. And this one is just if you know the first one, then the other one is easy. Just on the other one, just caused by, IBD. Okay. Okay. So basically, when it comes to, anything that could affect the ducts, you have the primary sclerosing cholangitis, you have the primary biliary, AMA, biliary. So basically, with the primary biliary cirrhosis, what you're looking for is I'm looking for AMA. antimitochondrial antibody. Boom. And when it comes to pulmonary sclerosis, what you're looking for is your IBD. It could be the ulcerative colitis or it could be Crohn's disease. Don't worry about that. We discussed it in IMED, so I'm not going to that anymore. I'll keep going. Hepatitis, I'm going to discuss this. So hepatitis A will go by itself. You see this a lot in poor hygienic countries. Usually this is by fecal oral. You should know that fecal oral. So you want to get hepatitis A vaccination. Drink good water, good food, and should be fine with this. Okay. When it comes to hepatitis B and hepatitis C, those could be transmitted through blood and fluid, or semen. And the biggest problem with these two is that it could lead to hepatic carcinoma. The next one here is your D. The D actually works with hepatitis B. So people that have hepatitis B could also get hepatitis D. Then E works with that. It looks like hepatitis A. Basically, you just gotta order the antibody against hepatitis E virus, and basically that will give you diagnosis. But the main thing you have to know about this is just fecal oral. This is by fluid. This two by fluid and hepatic carcinoma. And we discussed this already. Let's keep going. Oh, yes. Again, I'm not going to go into this. You guys know this already, right? Also the colitis and Crohn's. Yes, we're good. Skip lesion, right? Yes?
Yes.
Do you have a mnemonic for this one?
For me, the mnemonic that I use for this one is for ulcerative colitis. Ulcerative colitis is the colon. So only affect the colon. Ulcerative colitis affects the colon. So that's the reason why this is only limited to the colon, right? Whereby with Crohn's disease, it could affect any part of the GI, basically in the skip lesions. So that's why I remember it. Does it good? Does that work for you?
Yeah, great. Thank you.
Yeah. Okay. All right. Okay, this is very easy. Acute pancreatitis. Where is the pain with the patient that is having acute pancreatitis?
Goes to the back.
What is it?
The back, epigastric region.
Back epigastric. Exactly. Good. If I tell you a patient has a positive amylase, a positive lipase, and a decreased calcium, what does that mean?
Acute pancreatitis.
Acute pancreatitis. What's the colon sign?
It's ecchymosis around the umbilicus.
That's right. What about the gray?
Flank.
Flank. The way I remember that, C comes before G. So C front, G back. So, all right. So I'm not going to that. Oh, what's the number one cause of acute pancreatitis in the United States?
Alcohol.
Alcohol. Okay. But anyway, basically the most important two actually is gallstone and alcohol. Matter of fact, anytime you go to the hospital, when you're suspecting you have acute pancreatitis, the first thing they're doing is ultrasound of the right upper quadrant to make sure you don't have any, stones, because gallstone is number one cause, not number one cause, but one of the causes of someone just said something. Yes, thank you. Okay, anyway, so basically, do not treat a patient for acute pancreatitis without ruling out some kind of gallstone issues. Rule out gallstone, ask the patient good history to rule out if they've been drinking alcohol. Okay. And somebody said it already, severe pain in the epigastric area into the back. That's very important. Do this pain get better when they change position?
Yes.
That's right. Okay. Kind of reminds you of, remember that acute? Remember that acute something?
Yes.
You guys are remembering this. Acute pericarditis. When they change position, it gets better. Same thing with acute pancreatitis. They get better when they change position. Okay. When they lay down, impossible. When they stand up, they do well. Okay. Okay, this is the colon sign right here. That's what it look like. Okay. And that's your great Turner sign in the back and the flank. Okay. There's something I'm looking for here. I want to rush them. I'm going to go faster. Okay. The best way to treat acute pancreatitis, number one, you want to keep them MPO. That's the first treatment. You got to keep them MPO because the more food they eat is going to continue to stimulate release of the amylase and lipase and cause more pain. You want to make sure you, okay, stop any food. They call it GI arrest, okay? So, or pancreatic arrest or rest. Then after that, you want to give them nice fluid, okay, and give them some pain medication. Okay, the next one is appendicitis. Where is that located? You guys know that already, okay? The McBurney point, you guys know exactly what that is. Am I right? Are we good with that? Yes?
Yeah.
Okay. And basically, if you have an abdominal pain around the umbilicus, true or false, you have a late stage of appendicitis.
False.
False. So it's very important you remember that. If you have pain in the umbilicus area, okay, and it's reading now to left lower quadrant, you know that you're dealing with early appendicitis. Okay. Again, do you have to notice? No, but when you do your emergency medicine or when you do your general surgery rotation, they want you to notice the Rousing sign, the psoas sign, and the obturator sign. Okay, so that's the definition right there. If you want to take a picture, so you can just for tomorrow, you don't have to notice. It's not general surgery. Just remember this, for the future. Okay. Again, diverticulosis, diverticulitis. Diverticulosis is just pouching, okay, due to high fiber or low fiber. What do you guys think?
Low fiber.
Low fiber. So how do you treat a patient with diverticulosis?
High fiber,
More
low
fiber.
fat diet.
Right. And diverticulitis is pretty much of an infection. You have feces that is stuck into these pouches. The last you want to do is to give them high fiber because that's going to just burst those pouches. So you want to give them low fiber to treat them. You want to give them some fluid. You give them some antibiotics. And that's how you treat that. I'm kind of rushing now, so pulmonary. When it comes to pulmonary, lung disease. What time am I good on time? Jeez, I gotta hurry up. Lung disease. Basically, we have lung disease is divided into two. You have obstructive and you have the restrictive. Okay. The best way to differentiate between those two is to do a pulmonary function test. Okay. With a pulmonary function test, you'll be able to differentiate between obstructive or restrictive. With obstructive, basically you have your asthma, bronchiectasis, you have bronchiolitis, okay, and you have chronic bronchitis, emphysema. Question for you: Why? How do I explain this? How do I say this? I'm gonna ask later. So that's that. Then the restrictive, examples of that is asbestosis, TB, idiopathic pulmonary fibrosis, and sarcoidosis. So when it comes to obstructive, their problem is they are just having problem getting out, the air. They have problem exhaling, getting the air out. They get it in, but they can't get it out. So that's one of their biggest problem. Okay. Now that definition becomes very important when we talk about FEV1. Okay, FEV1. When we talk about it, becomes very important. Okay, so think about it. This definition: obstructive disorder. They having problem getting that air out. They having problem getting it out. Okay, When it comes to restrictive, okay, the problem with them is their lung capacity is so hard they can't expand. Usually, when you breathe, you're supposed to have an expansion of the lung, but the lung can't expand. The cavity can't expand because it's so restrictive. Okay, it's so stiff. So the biggest problem with this restrictive condition is that their lung capacity, their lung expansion is very low. Okay, and that definition becomes also very important. So when it comes to pulmonary function tests, so with patient with obstructive, again, their lung capacity is beautiful. There's nothing wrong with it. Okay. Their forced vital capacity with FVC is normal. It's beautiful. There's nothing wrong with it. Their only problem, okay, is just that they cannot get air out. Okay. They have a problem exhaling. Okay. If you remember the definition of forced expiratory volume is how much air can you get out in 1 second? They have a problem with that. Okay. So that's their biggest problem. So if you look at the ratio between FEV1 and FVC, which is pretty much the vital capacity, how much air can go into the lungs, these people, okay, they have low FEV1, and it makes sense. They can't get the air out. Okay, so basically their FEV1 to FVC ratio is going to be low. Now let's talk about restrictive. What is their problem? Their lung capacity is decreased, is stiff. Makes sense. And also the forced vital capacity is also reduced. But they can get the air out. To get out, that's not the problem. But they just have no expansion. So what will happen is with these people, the denominator, your FEV1 is usually normal, but this right here is usually reduced. So what's going to happen is, you're going to have increase ratio or normal. Normal is 0.8. Normal is 0.8. Does that make sense?
Yes.
Okay. I think you guys are tired. Should we stop?
No,
I'm
please
tired.
continue.
we're good.
No.
I'm tired. Is Nikolai here?
Yeah, I'm here. What's up?
Nikolai, what do you think of my presentation?
It was
at the
good. It
conference?
was really good. I liked it. I liked all of them.
Thank you. Yeah, I'm so tired. And after that, I have to rush into surgery. I'm
I
dozing
know.
off.
I
And
know.
tomorrow, I got to give a lecture tomorrow with the class of 2020. So I'm giving them a lecture on cuff pain.
We
Anyway,
appreciate
so,
it, Dr. Sam.
Yeah, just want to make sure you guys do well on the exam tomorrow. So let me just hurry up real quick. So again, just remember this, that the denominator, if the denominator is reduced, that means, the number is going to go higher or normal, right? This one is the numerator is reduced. That means you're going to have decrease. So that's why, obstructive is decreased, whereby restrictive is high. Okay. All right. I'm going to rush through this now. We don't need to send them over. Oh, good. The next one is asthma. This becomes very important, what I'm about to say, this slide. The first thing that happens with people with asthma is something is causing the initiation of the inflammation. Something is causing it, some kind of initiating factor, some kind of pollen, dust, something, smoke. Something is causing the reaction within the lungs. So the first thing that you see, and this becomes very important, the first thing that you see in people that have asthma, okay, is inflammation. Now, also, people with asthma, it could be anything causing this initiating factor. Also, allergies. Allergies could also lead to inflammation. So anyway, initiating factor or allergies, those two, the first thing that happens in asthmatic patients is inflammation. The first thing that happens in the asthmatic patient is inflammation. What is the best initial treatment for a patient with asthma?
Corticosteroids.
Yes. Thank you. Now, do you have to give only steroid? Absolutely not, because guess what? You still deal with something else. Once you get that inflammation, you're going to get bronchoconstriction and mucus production. Okay, so basically that's the sequence of asthmatic attack. Inflammation. Something that's causing a problem or allergic reaction, causing inflammation, Once you get inflammation, you're going to get bronchoconstriction. Once you get bronchoconstriction, you're going to get mucus production. Okay. So basically, the first thing you have to do is to give them some steroid to calm them down. Then you want to give them a beta agonist, okay, to reverse this bronchoconstriction. Okay. So that's very important. So true or false? Asthma is reversible.
True.
True. COPD is reversible.
False.
False. False.
Beautiful, beautiful.
Dr.
So these are
Ford,
the yes.
quick question. In the notes, the professor, I don't remember what her name was, but she mentioned not to give long-acting beta agonists for asthma, along with inhaled corticosteroids. So on the exam, do you want us to go with both, or should we just go with?
I'll talk about that in a minute. I'll talk about that in a minute. Okay, so you guys got this, you got this. Okay. The next I want to talk about, I'll discuss that in a minute. I'm going there. The next I want to discuss is when it comes to treating asthma, again, you want to start with your, inhaled corticosteroid, starts with an own, right? Then you have your bronchodilators, your beta agonists, okay? Then, if you remember, muscarinic receptors, their function actually called bronchoconstriction. But when they come to the muscle, they causes, skeletal muscle, they causes relaxation. So with this condition, basically want to give anti-muscarinic agent. So a patient that's got asthma, COPD, want to give anti-muscarinic, right? If they'll give muscarinic agonists, they're going to get, bronchoconstriction. So anti-muscarinic, and what you're going to hear is HUM, IUM, or late, so just FYI. So when it comes to treating asthma, okay, the first thing you wanted to do is to give them some kind of steroid. Followed by, now, some people say you should start with short-acting beta agonist. That's fine. Some people say if the asthma is chronic, you could start with long-acting beta agonist. So whoever asks that question, you make a decision. You could do either or. But the most important thing, you have to add, steroids. So you got a steroid and short, steroid or long. But you should never, ever start with long-acting, muscarinic antagonist for asthma. Always start with steroid and add short-acting steroid or add long-acting. Okay, and if it's not getting better, you can now add long-acting muscarinic antagonist. Okay, when it comes to COPD, opposite is the reverse. With COPD, you want to start with long-acting muscarinic antagonist, and you could add steroids to it if you want to, but you want to start with this and go that way. Any questions? Did I answer that question?
Kinda. I just thought in the notes it said not to take both inhaled corticosteroids with long-acting beta agonists. So are you saying to take either one? Either, like, if you're going to do one, do the ICS, but if you have the option, you can also do the long-acting beta agonist? Okay.
Yeah.
So don't do both at the same time.
That's again, for me, that's what I remember. People actually like the short acting first. Again, short acting should come first before the long acting. It's because they haven't acute, inflammation. But once they are stable, you could not just stay with, your long acting to kind of control the disease.
Got it. Thank you.
Okay. All right. Asthma, done. Okay, so when it comes to COPD, you guys know this already: emphysema, chronic bronchitis. Know this definition. Know this deficiency is very important to COPD. By the way, COPD is a combination of emphysema and chronic bronchitis. True or false?
True.
True.
That's right. Okay. All right. So what is the best way, okay, to reduce COPD complication?
Smoking cessation.
Smoking sensation, absolutely, right there. Smoking sensation, very well. Okay, So when it comes to asthma and COPD, they produce some product, especially a chronic bronchitis, they have some productive cough, whereby in asthma they don't really have too much. Asthma affects the upper airway, COPD lower airway, but the most important thing when it comes to the differentiation between these two is to do what? It's a test.
Spirometry.
Right, you wanted the spirometry, and also you wanted to do. Thank you. Somebody said it. You wanted to do a bronchodilator challenge. When you do a bronchodilator challenge, right? What do you think will happen to asthmatic patient? Would they increase
Asthmatic
almost
patients
close to
will get better.
normal? Exactly.
They'll
They will get better.
increase. Yeah, they'll
Right.
get better.
Exactly. Right. They will pretty much the FEV1, FEVC will be almost normal. Right. But what about COPD?
It will not increase or increase very, very little. Like the
That's right.
FEDC.
They will get some improvement, but not that much. Now, let us say I'm still confused. I don't know. Am I dealing with asthma? Am I dealing with both of them are improving based on my parametric test? What else can I do to really make sure I'm dealing with asthma?
Methacolon challenge.
That's right, metacolon challenge. That's right, metacolon challenge. And metacolon challenge is really to test for reactive airway disease, or they call it allergic airway disease. When you give this patient metacolon, it causes vasoconstriction. Guess what's going to happen to asthmatic patient? They're going to deep aggressively, right? But make sure you get ready your bronchodilator, to really give it to them. And once you give them bronchodilator, these people they will drop all the way to like even 0.6. Once you give them that bronchodilator, they just all the way up, back to if not even above 0.8 sometimes. But it's going to be a little low, but at least it will be much improved. But when it comes to COPD, nothing happens. So this bronchoprovocative test, metacolon challenge, is really to check if you're dealing with asthma or not, and especially if you have reactive airway disease. Okay, you guys know this already. Difference between emphysema and kind of bronchitis, bloater, and pink puffer. In emphysema, they are very thin. You guys know this already. They have a barrel chest. Okay. Any questions about this? We're good, right? Yes. Okay. So chronic bronchitis, basically bloaters. Emphysema, they're very thin. They have that barrel chest. They always lean forward, and they use a lot of the accessory muscles. Just remember that. What's your diagnosis here?
Emphysema.
That's right. Okay, the next one is bronchiectasis. What exactly is that? Bronchiectasis is just pretty much destruction of the bronchial wall or bronchioles due to some kind of infection. Okay, now if you remember, we have chronic bronchitis. With chronic bronchitis, you have mucus production. Mucus. There's a productive cough, but it's mucus, right? But when it comes to bronchiectasis, it's caused by an infection. So instead of you having a mucus production, you're going to get pus. Okay. So these people, they have a mucopurulent discharge. They have foul smelling sputum. Okay. So bronchiectasis, unfortunately, is irreversible. The number one cause of bronchiectasis in the entire universe is TB, but in a developed country is cystic fibrosis. And anytime you think of cystic fibrosis, you should also think of Pseudomonas. Okay. What is the best way to diagnose bronchiectasis?
Hazard resolution CD.
Where'd you get that from? Where'd you get that answer?
I just on the slide in front of me.
Your slide or my slide? I hope you. I hope you're gonna say the book, because I got this from the book. If you guys read the book, all this information from the book. All right. So that's the answer. I resolution CT, that's the best thing. And obviously, when it comes to brachiostasis, you have pus. What you have to do, you have to drain it. Okay, you have to drain it. Okay. All right. So just to make sure we understand this, chronic bronchitis, you get mucus. When you have bronchiectasis, you get pus. Okay. Bronchiolitis is usually seen in kids with RSV. Okay. And the best treat them is give them IV fluid and BiPAP. Okay. I'm trying to rush this. Okay. The next one is your restrictive, lung disease.
Dr. Sam, sorry to interrupt. I'm just about cystic fibrosis. You said there was an association. I missed it.
Yes, when you have cystic fibrosis, you should think of pseudomonas infection.
Okay, thank you.
Yeah. All right. So the next one is your resistant lung disease. Again, this is very easy. What you have to do is they will give you a condition and basically just kind of do association. So if you have a patient that is, coal worker, coal miners, they're gonna get pneumoconiosis. Okay, if you have a patient that works with glass or sand or silica, they're gonna get silicosis. If you have people that work in constructions, shipyard, working on a roof, they're gonna get asbestosis. Okay. The next one. Any questions about that?
No.
Good. The next one is sarcoidosis. Sarcoidosis. What is sarcoidosis?
Multi-organ system damage.
Right. Is it autoimmune?
Yeah.
So I mean, basically, you have some kind of, your immune cells pretty much destroying itself, and causing severe scars, especially within the lungs. There are problems in the lungs. Okay. And what you're going to see in the lungs, you're going to see this formation of granulomas, in the hilar. Okay. Now, sarcoidosis is the only restrictive lung disease that will give you a bilateral hilar granuloma formation. The hilar is located right here, right there, and you're going to see these bilateral granulomas. So this is the best example, and I got this from online. You see this granulomatous formation here, and you see another one here. So anytime you see those bilateral hilar formation, that's a pathognomonic for sarcoidosis. Again, this is from the book. So when you have sarcoidosis, you have bilateral hilar adenopathy. When you have TB, you have unilateral. When you have hypersensitivity pneumonitis, it's absent. You don't see any granulomas. Okay. Another thing that's very important to differentiate between this is that when it comes to TB, you have unilateral, adenopathy, but cavitation is very seen, and also you see pleural effusion. So if I tell you a patient with a TB, and they have pleural effusion, what kind of fluid are you going to see? Are you going to see transudative fluid or exudative fluid?
Exudate.
Exudative. That's right, exudative. So when you have an infection, when you have malignancy, when you have anything that could lead to itis, you're going to get exudative. Okay, so this is very important. All right, good. I'm gonna skip that. That's straightforward. We discussed that already. Okay. This is another one that I think is really difficult to understand. And I'm trying my best. So there is something called VQ mismatch. With a VQ mismatch, the V is your ventilation and your Q means flow is your blood flow. So if you look right, this is your alveolar. Okay, your alveolar is pretty much getting this is oxygen exchange here. This is gonna when you have a blood here, the blood is gonna give the CO2, and your alveolar is gonna give oxygen, and gonna get a converter from deoxygenated blood to oxygenated blood. So that's the way it works. That's what you call your BQ match. Your BQ match is when you have the right amount of oxygen going to the blood, and you have the right amount of CO2 going back into the lung to be exhaled. Okay, that's normal. That's beautiful. It's supposed to be like that, right? So the problem is when you have a BQ mismatch. So again, think about this. You have pulmonary artery that is bringing CO2, okay, deoxygenated blood, and basically, if you look at this, as once it get into the alveoli, the lungs, what will happen is you're going to get a exchange of gases. Then you're going to get beautiful flow of oxygen turning these blood into red and going into pulmonary vein and to the entire body. So what is a shunt? Okay. A shunt, again, if you remember that BQ mismatch. So a shunt is a BQ mismatch, where there is no ventilation or reduced ventilation. So when you have reduced ventilation, okay, and you have good blood flow, that's called a shunt. Okay. And where do you see that most of the time? What condition?
Acute respiratory distress syndrome.
That's right. That's right. So what are the things that could lead to shunts? If you have pneumonia, if you have pus within the lung, again, it's going to be very hard, for this alveolar to really transfer oxygen. If you have athleticis, lung collapse, it's going to be hard for you to transfer oxygen into the lungs, and you're going to get shunts. So BQ mismatch, you have good flow of oxygen, but unfortunately, you have no blood flow at all because of blood clot, pulmonary emboli. Okay, that's also a BQ mismatch. Again, we discussed already in emergency medicine, so I won't go into it, but there will be questions on this also. Clinical signs of PE, you should know that. You know that already. Let's save time. Western mark, your freshman sign, your acting hump. Okay, so again, this is a BQ mismatch. So which BQ mismatch do we have here? Okay, do we have good ventilation here? What do you guys think?
Yes.
Beautiful ventilation, right? What about perfusion? Do we have good perfusion?
No.
No. So where is the problem? Ventilation or flow?
Flow.
Flow.
So what could stop our flow?
PE.
That's right, PE. So that's the way you kind of go over this. Okay. And how do you diagnose PE?
CTA.
That's right. And how do you treat it?
Anticoagulant.
Right. So when it comes to acute respiratory distress syndrome, okay, it's not a primary disease. It's secondary to what's really going on somewhere. And there's this Berlin definition that says you must have these four things before you could diagnose a patient with acute respiratory distress syndrome. The first thing is it must be acute, from the name acute, meaning they have to be less than 1 week or less than 7 days. That's number one thing. The second thing is that you must have some kind of infiltration within the lungs, usually bilateral. Okay, you see unilateral, yes, but usually bilateral. That's the second thing. The third thing is your PO2 ratio to FiO2 should be less than 300. Okay. And the last one is that you must rule out any cardiogenic pulmonary edema, meaning that you must make sure the heart is fine. If the heart is not fine, you can't really say this patient is dealing with ARDS. So the heart has to be fine. If the heart is fine and the patient is having difficulty breathing, and it's within 7 days, and they have bilateral opacities, and the PaO2 and FiO2 is below 300, then you know you're dealing with the ARDS. Okay. I want to skip the rest of it and go to exudates. Exudates. Okay, exudates. Let's keep going. Go back. Acting up. Okay. Let me see if I can find what I'm looking for. Okay, right here. Okay, so when it comes to transudate and exudate, in transudate, the fluid is clear, and exudate, the fluid is a little, cloudy. Okay, this right has low protein, and this one has a high protein. This is caused by inflammation, infection, and malignancy. Okay, this you have to know your light criteria. Okay, the light criteria says that the fluid, the effusion, the fluid protein to the ratio of the serum protein has to be more than 0.5. Okay, for the protein. For the LDH has to be more than 0.6. Okay, and the fluid for, again, for the exudate effusion, the fluid of the LDH has to be 2/3. It has to be more than 2/3 upper normal of the serum LDH. Okay, so this you have to know. It's called the light criteria. You have to know it. They're going to give some numbers. They're going to say a patient has, a fluid protein of more than 0.5, fluid LDH more than 0.6. Is this transudate or exudate? And you're going to say this is exudate, kind of like that. You're going to get on the exam. Okay. The number one cause of poor effusion is CHF.
Dr.
Right?
Sam, can you explain it one more time? So if it's above 0.5, it's an exudate, is what you're saying?
Right. So when it comes, so the light criteria basically talked about exudative fluid. Okay. With exudative fluid, if you compare the ratio of the fluid protein, okay, and the serum protein, okay, you're going to have more than 0.5. If you compare the, fluid LDH to the serum LDH, it's going to be above 0.6. Okay. And the fluid LDH for exudative is going to be more than 2/3 upper limit of the serum LDH. So this really is for exudative fluid. Okay. When it comes to transudative, basically it's the opposite: less than 0.5, less than 0.6, and lower than upper 2/3 of the serum LDH. It's kind of the opposite. So my recommendation is just memorize one for exudative, and that's it. All right.
Okay, thank you.
All right. I think some of that thing that might get one of the gotcha kind of question, on the exam also. Again, just know the numbers. For exudative, above 0.5 is a protein. For the LDH, above 0.6, and more than the 2/3 upper limit of the serum LDH. So I think I got it from your slides. For me, the way I remember this, transudative is non-inflammatory, whereby exudative is inflammatory, it's infectious, it's malignant, any itis, okay, any inflammation is exudative. So what I did, I remember when I was studying for this many years ago, I just memorized transudative, and everything else, if it's not on this list, apart from that, iatrogenic. So iatrogenic, forget about iatrogenic. Apart from iatrogenic, I just memorized everything here. And basically, if this is not on my list, then I'm dealing with exudative. But if you hear infection, if you hear inflammatory disease, if you have malignancy, you're dealing with exudative. That's where I remember it. How do you treat this? You got to drain it. Okay. So again, poor effusion. You see right here, this is a poor effusion on the chest X-ray. The best way to do is to drain it. And once you take it out, you have to kind of send it for analysis for cytology and analyze it. Okay. Pneumothorax. We discussed this already. Pneumothorax is divided into traumatic and spontaneous. Spontaneous is divided into two. You have the primary and secondary. The primary is the patient doesn't have a lung disease. They're fine. They're young. They're a basketball player. They're long and thin, and they just collapse. That's your spontaneous primary pneumothorax. whereby a secondary, they have some kind of lung disease. Okay. Now, when you have shifting of the trachea, that's what's called tension pneumothorax. Okay. So a typical primary pneumothorax, healthy, young, tall, teen, and just passed away, just died, pneumothorax, or having chest pain. That's your pneumothorax. Okay. And what is the best way to treat a patient with pneumothorax?
Needle decompression.
Needle decompression. Good. I'm missing something. Where's my stuff? There's something I want to discuss. Sorry, give 1 minute. It's very important. Hey, go right here. I missed that. Okay. I want you to pay attention to this. So anytime you have fluid, okay, in a lung cavity, like a perfusion, pneumonia, atelectasis, tumor, so anything that will take on, mass. So mass and water. So when you do your when you do your percussion, you're gonna hear this dull sound or flat dull sound. The reason why, because the fluid, so the mass is absorbing it. So anytime you percuss and you hear dull sound, you know you're dealing with atelectasis, tumor, anything that will cause water within the lungs or mass. When you hear hyperresonance or tympanic percussion, tympanic sound on percussion, that is usually pneumothorax or emphysema, but mainly pneumothorax. But patient with pneumothorax, we have a decreased breath sound. We have distended neck. You guys know this already. They're going to get hypertension. They could get a shifting in the trachea. When you're talking about tension pneumothorax, this is a medical emergency that you want to put a chest tube called tube thoracotomy or need the compression to decompress them. So don't forget, hyperresonance with decreased breath sound, that's your pneumothorax. And if you percuss and you hear a dull sound, that's your water or mass. Okay, we did this already. Okay. All right, almost done. So the next thing is sleep apnea. Does anybody know what narcolepsy is?
It's when you fall
Yeah,
asleep
you randomly
randomly.
fall asleep.
Right. So these people, they lose, complete control, of their muscle. So there's disconnect within their brain and their muscle, which is called, cataplexis. So they'll be driving, and all of a sudden they just fall asleep. So that's called cataplexis. So it's an involuntary, involuntary. The word's involuntary, daytime sleeping or just pass out. Okay, that's cataplexis. That is not the same thing as your apnea. What is the definition for apnea?
It's when you don't breathe for more than 10 seconds while you're sleeping.
That's right. You got it. Absolutely. So basically, you have the obstructive sleep apnea and you have a central, sleep apnea. The most important thing is that, these people, they snore, right? They stop breathing and they gasp for air. Okay. One of the biggest problems with this condition is that these people, they could develop, heart disease, brain disease, and die early from this condition. So, how do you test for
Sleep study.
Scintigraphy.
it? That's right. Sleep study. So don't forget, one of the complications with sleep apnea, you got excessive daytime sleeping. Again, this could be controlled. They could control it. Whereby in cataplexis, this involuntary, the brain just not connected with the muscle. Okay. So you have impaired cognitive performance, you have poor quality of life, you have increased risk of motor vehicle accident, and you have pulmonary hypertension. Okay, so I just finished that. The last thing I want to discuss is rheumatoid. And we'll be done. That should be fast. What is the number one organ that is affected in a patient with lupus?
Kidney.
Kidney. What about a patient with scleroderma?
Lungs.
Lungs, okay. Good. All right, so real quick, I need a volunteer. I don't want anybody from my group right now because we did this already. Anybody else volunteer? All right, if it doesn't volunteer, I'll just ask question. If you have a positive rheumatoid factor and a positive anti-CCP, what is that?
Rheumatoid arthritis.
Rheumatoid arthritis.
Good. You have negative rheumatoid factor, negative anti-CCP, but you have joint pain in female lasting more than 30 minutes for 2 months.
Rheumatoid arthritis.
Which one?
RF negative.
That's right. So that's your pseudo-negative RA. And what gave it away is female. It could be male too, but they having pain lasts for more than 30 minutes for 2 months. For you to diagnose a patient with RA, they must have the clinical findings more than 6 weeks. So they could have negative rheumatoid factor, negative anti-CCP, as long as there are multiple clinical findings, and that's been up for more than 6 weeks, then you could diagnose RA. So that's a pseudo-negative rheumatoid arthritis. Okay. What about this patient? Negative rheumatoid factor, anti-CCP, but joint pain in males lasting for more than 30 minutes for 2 months with back pain.
Ankylosing spondylitis.
That's right. ANA, anti-double strand DNA, anti-Eastone, anti-Smith.
Lupus.
That's right. Anti-Eastone is what type of lupus is that?
Discoid?
Nope.
Drug induced.
Drug induced.
Where'd you get the answer from? Where'd you get the answer? How'd you know the answer?
The book.
That's what I'm looking for. God bless you. Yes, the book. Oh my goodness. Do me a favor, guys. After every exam in IMED, just go back to the book. You'll be like, God, oh my, that's right there. Anyway, drug induced. What about this one? Anti-centromere.
Scleroderma.
Wrong.
Lupus.
Wrong.
Limited scleroderma?
That's correct. Limited scleroderma. It's from the book. It's in the book. What about your anti-scleroderma 70?
Diffuse scleroderma.
Diffuse scleroderma. What about anti-RNA?
Scleroderma renal crisis.
Diffuse scleroderma, okay. And you know your gout already, you know your pseudo gout. What about this row SSA and SSB?
Sjogren.
That's right. You can see it in Sjogren's, and you also see in actually in lupus also. But Sjogren is number one. Good job. Okay, we discussed that already, so I'm going to skip that. We discussed that already. Oh, what is the best treatment for rheumatoid arthritis?
Methotrexate.
Sure.
That's right. That's right. Followed by what?
Biologic.
So always remember you want to start with non-biologic, then biologic. Non-biologic, then biologic. What is the biggest problem with biologic?
side effect.
What?
A TB infection.
Exactly. So you want to make sure you do not give them with a patient with hepatitis or a patient with TB. Okay, good. Which one is Botnairs and which one is Swan?
Proximal is boutonniere.
That's right. So if you guys remember my mnemonic BP. So for osteoarthritis and for rheumatoid is BP. Burchard is proximal. Botnaire is proximal. Does that make sense? You know, and the opposite is, whatever. Okay. There's no time to do that. We gotta go. There's no time. We gotta go. Healthy. Don't worry about that. Don't worry about that. What the hell is this one doing here? Oh, we got that. We did that already. Already again. We discussed this already. We discussed that. Non-biologic before biologic, right? Okay. What is this condition? Excessive absorption of iron causing joint pain and bleeding.
Is that Wilson's?
And this condition could also lead to liver cirrhosis.
Hereditary hemochromatosis.
Oh, you're too smart for me. You're too smart for me. Good job. You guys, what I just did there, I just combined those topics. Okay, anyway. What is the best initial treatment for a patient with ankylosing spondylitis, psoriatic arthritis, reactive arthritis? What's the first best initial treatment? What would you give them?
Immune suppressant.
NSAIDs?
NSAIDs. NSAIDs is always the first line of treatment for all spinal arthropathy, all of them, except if the patient have an active IBD, they want to steer from that because that's going to make it worse. But the first initial treatment is NSAIDs, followed by biologics. Okay. Okay, which one is this one? Can pee, can climb, can see.
Riders.
Okay. True or false? The best way to diagnose riders is to do a joint aspiration.
False, it's clinical.
False, because it's critical. Thank you. Good job. Let's keep going. Ankylosing spondylitis, we discussed that already. What is the number one killer in a patient with ankylosing spondylitis? What would kill them?
Restricted lung disease.
Restricted lung disease and cardiac disease. Those two will kill them. Okay. Now, another thing that I think is very important here that I wanted to discuss, actually, I'll discuss it later in a minute, is something called anterior uveitis. Uveitis is a deep bleeding within, or deep inflammation within the eye that affects the uvea. Basically, with all the spondyloarthropathy, all of them, they will have uveitis. All of them, they have uveitis, especially unilateral uveitis. All of them. Okay. Bilateral uveitis is usually seen in Behçet's. Now, there is something called scleritis. Where do you see that?
Rheumatoid.
Right. Scleritis is seen in rheumatoid only, whereby your anterior uveitis, especially unilateral, is seen in all spinal arthropathies. Okay. I'll show you in a minute. Where are you? There you go, right here. So look at this deep, injected eye. Compared to this one, it's like a little bit, red. When you see this is your rheumatoid arthritis. It's also called this, scleritis, whereby uveitis is really deep inflammation, deep red inflammation. Okay. This one is called disc disease. Disc disease is very similar to ankylosing spondylitis, and basically what you're looking for to differentiate between disc disease and ankylosing spondylitis is that disc disease is non-inflammatory, okay, and also the spinal column or vertebrae are maintained, okay. And the best way to diagnose it is to see this thing called floating calcium acidification, okay, in 4 consecutive vertebrae. So you could see it's like a candle wax that is flowing down the spine, but the joint spaces are maintained, right? If the joint spaces are not maintained, what do you call that?
Ankylosing spondylitis.
I know. But what do you call that?
Bamboo spine.
Fine.
Bamboo spine. So bamboo spine in late ankylosing spondylitis, you're going to see loss of the intervertebral spaces. But when it comes to this disease, these spaces are maintained. The only thing that's happening is almost like spraying a candle, and this candle wax is flowing down. When they flow down in 4 consecutive vertebrae, that is your dish disease. It's non-inflammatory, okay? Again, if you look right here, this is ankylosing spondylitis. You do not see any space. That's your late ankylosing spondylitis. If you look right here, you see spaces, right? Now you can see the floating aspiration right here. See the floating aspiration, like a candle wax? That's your dish disease, okay? Again, a late stage is bamboo spine. What do you see in the early stage of ankylosing spondylitis? Romanis lesions, that's right. What is the best, now be careful, what is the best imaging study to diagnose ankylosing spondylitis? MRI, thank you, MRI. But for some reason on the board exam, bamboo spine is always showing up. It's crazy, always. Anyway, ankylosing spine is done. We're not going to go into that. Let's get out of here. What is this? And psoriasis. Okay, good. With psoriasis, you're going to see plaques. We know that already. Don't forget, arthritis middleins is seen in rheumatoid arthritis, atrophic shock, and also in psoriatic arthritis. Okay. What is acrolysis or acrolysis? Anyone?
That erosions of the distal phalanx.
Joint space destruction.
That's right. You got it. Pencil on cup. You guys know that already.
Sorry, what was acrolysis?
Acroasteolysis is an erosion of the distal phalanx, which is being shown here. Erosion of the distal phalanx, right here.
Some quick for the acute stage of ankylosing spondylitis, you said something appears. I didn't hear it.
You're gonna see Romanis lesion. Romanis lesion.
All right, thank you.
Okay. Are we good? This question about the acroasteolysis? Yes.
Did you have a picture up of the Romanis lesion, or can you go back?
I don't think I have it. We need to know. I don't think I have it, but I'll tell you, it's almost like, remember your gout? We have the rat bite, your Mattel sign. Remember that?
Yeah.
It looked just like that, but on the spine. It looked exactly like that, but on the spine. It's like an erosion of the spine. They call it the Romanis lesion or the corner sign. So anyway. All right. So we got that. Ivory phalanx, you guys remember that? Right? So you should know that. Okay. Arthritis middleins, we talked about that already. Again, NSAID, the first line, we discussed it. Keratoderma banoragicum, right? It's a skin lesion you see in riders. Stomatitis you see in riders. Delantis, okay, also in riders. Just make sure you remember that, right? Delantis, okay. You have a stomatitis. Just remember that. What else? Reactive arthritis. So let me see. We did that already. I'm gonna skip that. gonna skip that. There's something that I want. Gouts. That's right, gouts. Lupus, we did lupus already. Oh yeah. What is antiphospholipid syndrome? Anyone?
They have problems with coagulation.
Miscarriages in pregnant women.
Do they get more clot or less clot?
More.
More clot. Is this common in pregnant women or not in pregnant women?
Pregnant.
Pregnant.
Is it common in lupus or not in lupus people?
Lupus people.
Lupus, exactly. So basically, you're going to see this condition in lupus, and if it happens in pregnant patient, again, this I got from your book. They're going to get spontaneous abortion. The best treatment for these people to put them on anticoagulation. A long time anticoagulation, you gotta load them up. Okay. What's the condition? What's the diagnosis?
Burgers.
Nope.
Chilblain.
I'll give you a clue.
Hernia.
I'll give you a clue. You are. It's not clear. It's not clear. It's telangiectasis in the proximal nail fold. Telangiectasis in the proximal nail fold. What is
Crest.
crest? Thank you. Thanks. Yes, sclerodoma. So when you have a it's not clear. It's not clear. But when you have telangiectasia in the proximal nail fold, you see that in sclerodoma and dermatomyositis. But anyway, sclerodoma, crest. Now, when it comes to osteoarthritis, what is the best way to treat them? Obviously, you want to give them NSAIDs. Can I give them injection? Why not? To stop the pain, to stop the inflammation. Can I give oral steroid? Not really. But the best thing is to NSAID. Give them NSAID, and do surgery.
Doug, can you go back to that slide for 1 second?
This slide?
Yes. Thanks.
So treatment is NSAID injection, right? And also you can even give them some kind of viscous supplements. Almost done. I'm not going to RA again. Sclerodoma, we discussed it already. Crest, you guys know what a crest means? Okay, limited sclerodoma is anticentromere. We discussed that. Sclerodoma, what do you call that? That's sclerodactyly, right? Again, limited, you have anticentromere. Diffuse is 70. Sjogren's disease. You have dry eye, dry mouth. That's my gout. I want to get to, there you go, gout. True or false? Aspirin, low dose aspirin could lead to gout.
True.
Alcohol could lead to gout.
True.
Beer could lead to gout.
True.
Cherry, be careful now. Cherry could lead to gout.
Cherries?
Yes.
Like the fruit?
The fruits, the drink.
Wait, what? Can you spell that?
Cherries.
Doesn't that treat it?
Cherry.
False. Doesn't it
Why is
help
it
with
false?
Treats it.
Yes. Which one doesn't help with gout?
cranberry?
Exactly. So cranberry will make gout worse, whereby cherry drinks or cherry fruits will make gout better. Okay, they should know that. Let's see, what else am I missing? Motel sign is seen in acute gout.
False.
False. Let's see what's my missing. You should cover everything. Discuss that. There you go. That's what I was talking about. So remember, cranberry, don't give it in gout patient. Cherry, yes, want to give it to them. Okay, this is so important when it comes to treating gout. Okay, you have to know are you doing acute gout or chronic gout. With acute gout, okay, What is the first line treatment for acute gout? And everybody's gonna get this wrong.
NSAIDs?
That's right. Good. NSAID. For some reason, people always say cortisone. Cortisone is not the first line. It's always NSAID. Okay. The second, I mean, you can also give cortisone as acute gout, but the first one to give is NSAID, followed by cortisone. When do you have to give cortisone?
Within 24 hours.
Within 24 hours to prevent chemotaxis. Very important. Can I give injection into the joint to help with gout?
Yes.
Right. What if I have a gouty attack that affects 3 joints? Can I give injection to all 3 joints?
You should do it orally.
Exactly. So basically, you want to try and give injection into one joint, really. You want to push it for 2, but never 3, ever. They want to do oral. Okay. For chronic gout, okay, it's very important when it comes to urate lowering therapy drugs. When you're going to start your urate lowering therapy drug, you want to make sure you add what? What do you have to add with it?
And then NSAID.
NSAID or colchicine. The reason why that is because you're going to get, activation because you're taking out so much uric acid. And basically what will happen is that you're going to see reactivation of gout. So you want to put them on, acute gouty medication. You can't leave it by itself. True or false? Once you start a patient on urate lowering therapy drugs, you should never stop it.
True.
That's right. That's true. That is very true. Let me see, what am I missing? Okay. So if you have a patient with, let's just say, they are overproducer, you want to give them allopurinol for vasostat, right? Okay. What about people that are under excreta? What do you want to give them?
Probenecid.
Right, probenecid. That's right. What about people, if you remember there was a question on the quiz, what about people that you try allopurinol, you try probenecid, it's not helping? What else can you give them?
Pegloticase.
Yes.
Pegloticase. What is the biggest problem with pegloticase? Again, these people will this medication will cause reactivation of gout. So you want to put them on acute medication like cortisone or whatnot. Vasculitis, you do not have to know vasculitis. It was not discussed, so we took those questions out. Let me just make sure I got everything. What is this?
Ascites.
Good. What is this?
Quick question, Dr. Sam.
Mhm.
For the allopurinol and the febuxostat, that's for the under, right? Why probably
Yeah, so basically for overproducer, you want to give them allopurinol and for give them allopurinol and for vasostat. But for under a producer, you want to give them probenecid.
All right, thank you.
Okay. Am I forgetting anything? Okay, I think we've covered everything. You have any questions for me?
That was
If not,
whatever.
I'm tired.
Thank you very much for doing this, Dr. Sam.
I'm exhausted.
Much appreciated.
Thank you.
Good night, guys.
Thank you, Dr. Sam.
Thank you.
All right.
Good night.
Thanks, Dr. Sam.
All right.